interpersonal skills and human behavior. Why are first impressions so important? First impressions are so important. They give patients the confidence and assure them that they are getting the most quality care. First impressions mean physical dress and appearance. So a clean scrub top and pant bottoms at the right length, proper fitting uniforms, having a positive attitude, being confident, showing compassion, and always smiling. Proper dental hygiene is also very important as a medical assistant. First impressions always address the patient by name. Some clinics have different policies. Some clinics prefer that you call patients out of the waiting room by Mr. or Mrs. Johnson, or some clinics prefer that you call them Mary Johnson and then verify the date of birth once you get them out of the waiting room. So it really depends on clinic preference for this. Be aware of the personal life of the patient. It will show him or her that you care enough to ask. A lot of times, many physicians will note in their medical record charts a life event, like they are going on vacation, they have a daughter graduating, they have a son going to Iraq, that sort of thing. Ask them about those events at their next visit. It shows that you may have remembered when really you probably didn't, but you took the time to look and you took the time to ask. Personal life events oftentimes directly affect health, so it's really important to ask those questions because that is usually a gateway to why are they there for the visit. Staff members of the facility are in familiar surroundings and already have some information about the new patient. Generally, we try and get medical records way in advance before seeing a new patient. So we already have that background information. However, the patient knows nothing about the staff members. So it's really, really important to introduce yourself and your role in the medical office. It's as simple as saying, "Hi, my name is Tara. I am Dr. Johnson's medical assistant. I will be assisting you today," and bringing them back to the room. Verbal communication. It's important that our communication is professional, that we avoid slang or improper English. So terms like you know, or y'all, or using excessive ums, or using K instead of okay. Those things are all considered slang or improper English. So trying to cut them out of your verbal communication as much as possible is really important. It's also important to enunciate and pronunciate words correctly, especially medical terminology when you're speaking with other staff members, such as the physician or a nurse practitioner. But pronouncing and enunciating words that are oftentimes pretty familiar with patients is also important. A lot of times we try not to use medical jargon with patients. We try to communicate at an 8th grade reading level where everybody can understand. Avoid using sarcasm or caustic remarks. Eye contact is critical. Always be professional, so words and sounds, your pitch in which you say something, or your tone of voice in which something is said can be interpreted in different ways. And sometimes the word choice also is really important in getting your message across. Making verbal communications clear and concise is also very important. You don't want to confuse the patient before they leave the office. Nonverbal communication. What is involved in body language? Gestures such as head nodding or crossing of the arms or crossing our legs can all mean something in our body language and can portray a totally different message than what we really wanted to. So we have gestures, mannerisms, appearance comes up again, self-esteem and confidence. Self-esteem, are you slouching? Are you standing up straight? Are you hunched over? Those sorts of things. Vocabulary, facial expressions. Are you smiling? Do you have a grimace on your face? Those can all be interpreted by patients as disinterested. If you have a grimace or if you look confused, that doesn't tell our patient that we are very confident in what we're doing. So minimizing those conflicting facial expressions that a patient might interpret as, we don't know what we're doing, we don't care, that sort of thing. We always want to have a caring attitude. So no matter what happened at home, you broke up with your boyfriend, you are getting a divorce, you just got in a car accident, you have to check that at the door. You don't want to bring that to work with you. So leaving that at home, put the smile on the face, go get your patient out of the waiting room and pretend like something did not even happen. Another example is you did something horribly wrong and the physician chews you out. You still have to go out to that waiting room, get your next patient, and pretend like nothing ever happened. So getting really good at masking what your true feelings are and giving that patient 100% of your attention and the attention that they deserve. Spatial separation, or proxemics, is the study of spatial separation. So public space is 12 to 25 feet, social space is 4 to 12 feet, and personal space is touching to 1.5 feet. So I always tell medical assistant students to try and remain in that social space. So at least 1 arm's length away from the patient is about appropriate. You don't want to be any closer to a patient unless they invite you into their personal space. Like they go to try and hug you, or they go to try and touch your shoulder. That's different. We do not want to initiate that going into their personal space. Cultural and environmental influences. So cultural influences that need for the individual space. So a lot of times our different nationalities may not like the touchy-feely, and sometimes as an empathetic gesture we will touch the hand or we will touch the shoulder of a patient. Some nationalities don't like that, so we need to be aware of that. Some nationalities don't like eye contact. Some nationalities, they are very skittish when you go to touch them. So boundaries, sometimes when you go beyond that boundary that they are comfortable with, they will back up if you are too close. Touch. No words required for accurate expression. They are comforting. Be careful with touch because it can be considered inappropriate and you don't want to end up in a righteous situation. Patients of sexual harassment will shy away from you, so be careful and cautious and conscious about that, and be sympathetic towards that. Communication. So the sender encodes messages through channels. The receiver decodes the messages based on the understanding. So there is what is called noise. There's internal noise, which is the self-talk. There's external noise, which is background noise. Maybe the radio is playing, or somebody else is talking, or the phone is ringing. There's a lot of different background external noises. And then there's psychological, which are those thoughts that are going through the head while that message is trying to be delivered. Feedback. There's verbal feedback, so summarizing what the patient said. or having the patient summarize what you said. And then there's nonverbal. Nonverbal is head nodding, maybe leaning back or leaning forward into the conversation, are all nonverbal pieces of communication. There are 3 different channels of communications. There's words, written messages, and body language. Listening, important to listen, important in all interpersonal relationships. Active listening, so you are listening to a patient after you have asked them, what brings you into the office today? And they are listing off all these things. At the end, you will want to do a paraphrase of what they said, so a shortened version, that means a shortened version of the main concepts of their complaint that they just told you. Patient-assistant relationships, so sometimes you will have patients who don't have anybody else to talk to. So they will come into the office and they will talk overly long, and they develop that relationship. They trust you. They trust that you may or may not tell somebody, depending on what it is. If it's something that bounds you legally to report, obviously you have to tell somebody. But otherwise, everything else is kept confidential. So, warning against advising. So medical assistants are not qualified to give advice. Patients make treatment decisions. You are an extension of the physician. Accurate professional communication is a must. And never withhold any information, especially from the physician. Say a patient says, oh, please don't tell the doctor, but this happened. You are obligated to tell that physician, and you need to tell your patient that, I'm sorry, but I do need to, report this incident. You need to be upfront about that communication. We as medical assistants are not qualified to give any advice, but a lot of times you will have the patient where you take the blood pressure and they will say, well, what is it? And you tell them the number and they say, well, is that good or bad? Technically, we can't tell them that it's good, bad, or indifferent, because that is technically advising. But we can tell them, well, the normal blood pressure for a person is 120/80. If you're slightly over that, you're considered pre-hypertensive, or the blood pressure is a little bit over what we would like. If you're over 140, that means you're hypertensive and we may need to change some things. Let's discuss it with the doctor. Those are good points of saying, well, the normal person is, that's how you kind of get around that with patients. You don't want to tell them, it's not my job to tell you whether it's normal or not, or I can't tell you that. That sends a cold message or a message that you don't really care. So we want to avoid that and have some different verbiage like, well, the normal ranges are, and give it as an opportunity of patient education. Observe carefully, so keep eye contact, look for signs of trouble. Patients who do not maintain eye contact, or they have bruises all over their arms, or are skittish when you try and approach them to put the blood pressure cuff on. Observe those things and report if necessary. If crying, ask the cause. You're really upset today. What's going on? Reassure patients of safety. Be aware of abnormal behaviors. Use correct documentation. Psychological disorders. Psychological disorders is a behavior pattern that occurs in a patient that causes distress on a disability that is not the norm for development or the culture. Some are better understood than others. Oftentimes we are treating with medications. There are 3 different treatment methods though. There's the psychoanalytic, which is the face-to-face, such as counseling. Then there's the cognitive behavioral, which is founded on a deficit in thought process. And then you have the medical model, which is the drug therapy. There are several different types of defense mechanisms. So verbal aggression is obviously the yelling and swearing. Sarcasm is a type of bullying. Rationalization offers excuses for what is done. Compensation makes up for behavior. Regression revisits earlier mental states in life. So say you have a 17-year-old girl who is coming in for an injection and starts acting like a 5-year-old. Crying hysterically, throws a temper tantrum. That's a good example of regression. Repression, they change the subject. Apathy is a lack of feeling or emotion. Oftentimes won't say much. Displacement is a venting to someone else. Denial, they deny what just happened. Physical avoidance, pretty obvious what that is. And then projection is where they question people surrounding them why they are getting the wrath for something someone else has done. So projecting their thoughts pretty openly. Types of communication, there's assertive, aggressive, and passive. So if you have an MA who is, say you are the MA and you are severely behind in the clinic, way behind in rooming your patients and giving callbacks to the doctor, which sometimes does happen, the passive MA will, and say in this scenario that there are other coworkers around you to help. So the passive MA in this scenario would not ask the coworkers to help. The aggressive would yell at somebody and say, "Why aren't you helping me?" And the assertive one would approach somebody nicely and say, "Hey, I am really far behind. Would you mind rooming my next 2 patients, please?" So that's an example of all 3. The next scenario that I'll present to you is a patient is really upset because you are an hour behind. They've been waiting in the waiting room. There hasn't been very good communication. And when he comes back from the waiting room, he's like, "Gosh, you just can't get it done. You don't know what you're doing. The reason why you're so far behind is because you take forever and you aren't very competent." So the passive MA wouldn't say anything. The aggressive MA would potentially go off on them and say, "This is what is going on. You know, we've had some really sick patients and that is totally not the reason why we are far behind." The assertive MA would say, "I'm sorry you feel that way. I apologize for running behind. We had some scenarios come up in the clinic that were not anticipated. And if you would like to talk to my manager, you can go ahead and do so. And I can get her if you would like." And more times than 10, they don't want to talk to the manager. Just that apology and your acknowledgement takes care of that. So as medical assistants, it's really important to have that assertive behavior. We don't want to be passive, but we don't want to be aggressive. It's really important to have that assertive behavior. Ask for help when needed and be upfront about your communication. Don't try and run away from it, but then don't try and go to the other extreme where you are chewing out people and making people even more angry. You want to minimize the situation, but not avoid it. Resolving conflict. Expect conflict. Allow expression of legitimate opinions. Listen to and consider opinions fairly and honestly. Don't interrupt people when they are trying to explain. Don't insist on being right all the time. And avoid judgment and placing the blame. Boundaries. Be aware of nonverbal signals. Indicate, limit, or extent. Prevent awkward situations. Do a self-inventory. Or avoid the passive-aggressive communication. Barriers to communication, so physical impairment, such as visual impairment or hearing impairment. Language, which is meaning our non-English speaking patients, so especially in the central Wisconsin area, we have a lot of Spanish-speaking patients or Hmong-speaking patients. And overcoming those barriers in communication, so having an interpreter available. Some employees are bilingual. The other alternative, if we don't have a physical interpreter, is some facilities have what's called a language line, where you call this line and they interpret the conversation as you are in the office visit. However, it is pretty expensive. They charge by the minute. Prejudice. So personal or social bias. So bias against people who are obese, thinking that they're lazy. Divorced. Homosexuals, there's a lot of prejudice against homosexuals. Race, sad to say, but there still is some prejudice against race. And then the biggest one I would say in the healthcare community is welfare recipients. Those patients in Wisconsin that are on Badger or Medicaid, there's sometimes some prejudice against them. And a lot of times it's just personal self-thought. Usually it doesn't compromise care, but we do have those prejudices in mind. Stereotyping. And then perception. Our perception is always based on our past experiences. So if we had a bad experience with, say, somebody who is a homosexual or might be, look at the situation in Missouri where a black guy was shot by a white cop. It really does set our perception in how we communicate with those groups of people. Stages of grief. Elizabeth Kubler-Ross came up with the stages of grief. The first stage is denial. So I'm going to give you a scenario of all 5 stages. So the first step, denial. My dog isn't sick. He doesn't have cancer. What are you talking about? Bargaining. I will pay the vet if she can get rid of this cancer. I will give you anything to get that out of my dog. Make him better. Do whatever you have to do. Anger is the third stage. Why me? Why does it have to be my dog that gets cancer? Depression, where you feel regret. Why didn't I take him to the vet sooner? Why didn't I take the dog to the vet sooner? Why didn't I do this or why didn't I do that? That depression, that feeling of regret. And then acceptance. You eventually become ready to lose your dog. You're okay with it. You say you don't want him to suffer anymore. Those are the 5 stages of grief. Empathy. It's always important to acknowledge, use gentle touch and kind words. Communicate care. Carefully choose words and phrases. Ask questions is always helpful. How are you doing since your dad died? Multicultural issues. Oftentimes we have isolated thinking. Everyone feels this way. Vast differences from country to country. Differences within the same country even. There's a lot of differences in the United States, from East Coast to West Coast or from the North to the South. There are a lot of variances in culture and how we deal with things. Stereotypes. Media influences our thinking. The news oftentimes influences our thinking, can sometimes make our thoughts worse about a situation or better. Maslow's hierarchy of needs. So with Maslow's hierarchy of needs, you have to establish the base at the bottom in order to have anything above it. So the first thing, in order to survive, we have to have our physiological needs. So breathing, food, water, shelter, clothing, sleep, all those essential things in order to survive. Then it's about safety and security once we have the physiological needs. So safety and security of health, employment, property, family and social stability. Once we have obtained those in our life, then we can move on to the next stage, the third stage, which is love and belonging, developing friendships, families, intimacy, a sense of connection among people. Once you have done that, then you can move to the fourth tier of the pyramid, which is self-esteem. You build your confidence, sense of achievement, respect of others, the need to be unique and not like everyone else. Once you have done that, then you can go to the final and fifth stage, which is self-accusation, where we develop morality, creativity, spontaneity, acceptance, experience purpose, figure out meaning and inner potential. This is where we maximize our potential in life. Adaptions based on individual needs, so approval, acceptance, and achievement, a good night's sleep, healthy nutrition, positive relationships, and healthy self-esteem. How needs affect work performance. So if we have low self-esteem, we are not going to have a positive outlook on life. We are not going to be able to help people be positive and encourage them that they can get through this tough situation. And that happens a lot in healthcare. Self-improvement. Procrastination is a big one. Procrastination is oftentimes a result of self-doubt, fear of failure. Comfort zones, fear of new things and the unknown. Is it safe? Am I going to be okay to do that? We often question these different things when it comes to our potential needs.